Welcome everyone to this exciting webinar. My name is Pragashini Murugan. I am the program officer from the ITPC Global. Sorry about that. From the Build Resilient Community Strategic Focus Area. I would like to officially welcome you to this very exciting and important webinar titled Community Data in Action, Community-Led Monitoring for Diagnostic and Laboratory Services. This webinar focuses on the results from the rollout of a community-led monitoring project in Burkina Faso, the Democratic Republic of South Africa, as well as Sierra Leone, which took place last year. Okay, so I would like to officially welcome everyone, and please ensure that if you need interpretation in French, it is available. If you look at your right-hand corner of your screen, there's a little globe. Please press onto it as it will have the respective languages for interpretation, either in English or in French. So for today's agenda, as I go through the agenda, I will also present our panelists. To start off with, we are joined by Nadia Rafif from ITPC, who's our advocacy and influence lead. And she, just share my screen again. Yeah, so she's our advocacy and influence lead at ITPC. She will provide the framing remarks, followed by Collins Otieno from ASLM. We are also joined by clinical advisor Tracy Swan, who will go through the WHO recommendations on our World Health Organization recommendations on diagnostics, followed by a session where we will provide specific case studies or country findings from DRC, Burkina Faso, and NETIPS. Anj Mavulo from DRC, Christian Nissan from Burkina Faso, and Martin Eli from Sierra Leone will provide insights into their country context, some of the key findings, and monitoring the impact of the funding cuts, and as well as key takeaways, while I will provide an overview of the summary of findings. We will have a Q&A discussion session that will take place thereafter, and please feel free to introduce yourself in the chat, as well as add any questions onto the Q&A box, and we will make sure that we will answer it. The last session will look at some of the closing reflections, as well as wrap up. With that, I would like to hand you over to Nadia Rafif, who will go through or provide some of the opening remarks. Thank you.
Thank you, Pragashini. I just want to give the floor first to Collins from ASLM, as we discuss, and I will jump in after. Please, the floor is yours, Collins.
Yeah, thank you, Pragashini, and thanks, Nadia. So welcome, everybody, to this echo session. My name is Collins Otieno. I'm a portfolio lead at ASLM, and I also support the LabCoP, the Laboratory Systems Strengthening Community of Practice. As you know, we have worked with a number of countries, 24 African countries, to share best practices in laboratory system strengthening. But also, at some point, we also need to learn from the recipients of care who we serve. And we are honored to have worked with the International Treatment Preparedness Coalition, ITPC, as a civil society, and also to give us a perspective of what happens in the field as we strengthen laboratory systems. We are also happy to include 3 country experience, so 3 countries that are members of the LabCoP, and we really look forward to see some of their findings of this work that was done last year during the funding cuts. And we hope to learn on if systems are now resilient to weather funding cuts and also to inform investments into the future. So thank you so much, and I look forward to also learning in this session. Over to you, Nadia. Thank you.
Thank you, Colleen, and good afternoon, everyone. And before moving forward, I want to acknowledge on behalf of ITPC and thank the African Society for Laboratory Medicine and LabCoP community, and more particularly Collins, who is with us today, for their sustained leadership on strengthening diagnostic system across the continent, and also for their technical partnership and financial support they provide to ITPC and partner to be able to do this community-led monitoring possible. So, yes, we are meeting today at a pivotal moment for global health. Last year, we have seen the January 2025 PEPFAR stop work orders, the USAID disbandment, the sudden funding freeze in many of your countries, and the growing uncertainty around global HIV financing. So what we are witnessing, it's not only a funding gap, but it's exposed also structural fragility, right, of some of our system. So like you will hear from the partner, and also if you read the report, that the funding cut reveal how deeply laboratory system remain donor dependent. So when funding shift, what happened concretely at country level? For diagnostic, you will hear that CD4 testing volume drop sometime by 70%, like in Burkina Faso, or that viral load monitoring fell sharply in the DRC, and as importantly, across the board, community outreach and psychological support were stopped or very slowed down. So this is not theoretical, right? With this exercise, we were able to measure it, to document it, and to measure the impact on recipient of care. So why diagnostic matter now more than ever? Because we don't hear a lot about diagnostic in all the, when we hear about the impact of the crisis. So diagnostic are even more critical today, and WHO guidance is clear. They are not an isolated technical intervention. They are really a part of a prevention and treatment continuum. They anchor the HIV response. So we talk about HIV testing, early infant diagnostic, CD4 for advanced HIV disease, viral load monitoring, TB screening, and many other. So without diagnostic, we cannot detect treatment failure, we cannot identify advanced HIV disease, we cannot protect infants, we cannot prevent transmission. So when we say that it doesn't matter, and I will let Tracy elaborate how many tests a facility perform, that's not the only thing we need to look at, right? We need to look at if people understand their result and if there is action that follow. And so diagnostic are not at all optional. They are the backbone of the continuity. And why CLM is essential? Because community-led monitoring allow to identify dysfunction, and it's led by community, and it can show gap across the diagnostic cascade. It can look at stockouts that are not recorded in official report. It can look at delay in viral load result, and many other things. So it does not replace national system, but it strengthens them because we all here for the same goal, right? To unlock the bottleneck and to try to find solution together. And you will see that the three countries already action some recommendation and have worked with their national partner to strengthen procurement planning, reinforce maintenance system, or institutionalize communication between government and community actor. I will end by saying that these days prevention is dramatically being deprioritized, and in this context, it's often the first to be caught. Community tracing disappear, psychological support outreach is weakened, but prevention depends on diagnostic again. So we cannot talk about prevention without talking about laboratory system. Testing is not only a sample; it's like a contract. Otherwise, diagnostic become only a statistical number exercise rather than a clinical intervention. So I'm gonna position this webinar today. It's about how to make CLM a routine exercise to be like a warning for national system. We're going to talk how to protect laboratory system in this financial landscape and how to continue to push to align diagnostic with WHO standards. And I will stop here and give the floor to Tracy, who will speak to that very shortly. Thank you, everyone, and thank you, everyone, for the effort also at country level. Given the circumstance, you have done this exercise in a very short amount of time and provide very good quality data and recommendation. Thank you. Tracy, the floor is yours.
Hi, everybody. I just wanted to show my face for a minute before I turn my camera off. There's a massive windstorm here, and I'm not really sure if my internet access will continue, but nonetheless, here we go, and thank you for joining.
So you want to, okay, yes, you share your slide. Thank you, Tracy.
Can everybody see them well?
Yes, we can. Thank you.
Yes, we are able to.
Okay, so I will be discussing what was monitored and why. And as Nadia said, it should never be testing by itself. Testing also includes other services, information counseling, referrals, and explaining delivering the results, as well as taking recommended actions as indicated based on what the results are. This is all part of testing. It's never just taking a sample. People have the right to and need to know why a test is being done, what the result means, and the actions that need to be taken based on their test result. And it really doesn't matter how many tests a healthcare facility does. If people never get their results, if they get them really late, months later, or they don't understand their results, and when no actions are taken when called for by their test result. So what was monitored for this project and why? These were really priority tests. So HIV testing, including self-testing, because it enables the initiation of PrEP and linkage to life-saving antiretroviral therapy and other HIV services. And early infant diagnostics. This is not the same test that a person would get, an adult, if they walked in for an HIV test. Infants carry their mother's antibodies until they're 18 months old. So if their mother is living with HIV, they will test positive even if they don't actually have the virus in their body. So they need to have a viral load test to diagnose whether they're actually living with HIV or not. And the reason why it's so important to diagnose infants early is because the death rate among undiagnosed, untreated infants living with HIV is really high. 30% will die within a year, and 50% will die within 2 years, and this does not need to happen. So what else was monitored during this project and why? CD4 cell count, which is really a measure of how healthy the immune system is. And WHO says CD4 cell count is the preferred method to identify advanced HIV disease among people living with HIV. And this is because people living with HIV who have 200 or less CD4 cells, they need a special package of care because they're vulnerable to serious illness and death. And it's super important, especially in the context of funding cuts that have reduced access to HIV services. People may be presenting late for testing when they already have advanced HIV disease, or they may experience disrupted access to treatment, or in the worst case, which I absolutely hope never happens, it may become necessary to prioritize access to HIV treatment to people who are at the greatest risk of illness and death. So the CD4 count is something you really need to have at when someone tests positive. You do not want to do a CD4 cell count after someone has started treatment because HIV treatment helps the immune system to recover and the CD4 cell count will go up. So it's after someone tests positive. If treatment failure is suspected, if someone drops out of care, if someone is really ill, etc. And viral load testing identifies HIV treatment failure. An unsuppressed viral load is over 1,000 copies, and it puts people living with HIV at increased risk of treatment failure, illness, and death, and they can pass on the virus. People with a suppressed viral load do not transmit HIV to sex partners. And people who are living with HIV and have treatment failure need enhanced adherence counseling, continued monitoring, and if necessary, to switch their antiretrovirals. So the last thing in this package of diagnostics is screening for tuberculosis. It's a WHO recommended 4-symptom TB screening, asking people, have you had a cough? Have you had a fever? Have you had night sweats? Have you lost weight? Every person living with HIV should be asked these 4 questions at every visit to a healthcare facility, as should all hospital inpatients. And the reason for this is tuberculosis is the most common illness among people living with HIV, and they're up to 22 times more likely to fall ill from TB than HIV negative people. And although TB is preventable and curable, 150,000 people living with HIV died from TB in 2024. So diagnosing and treating TB in people living with HIV, especially early, before treatment costs become catastrophic, it saves lives and prevents onward transmission of tuberculosis. So those are what was monitored and why they're important. I thought we'd just take a quick look at to see if WHO and national guidelines in Burkina Faso, the Democratic Republic of Congo, and Sierra Leone are aligned. And yes, they are all aligned in their recommendations. There are some slight differences, perhaps in timing, but and some of this has to do with national priorities, what kind of prevalence of certain opportunistic infections are, etc. But they're all in alignment. And this is actually really important because if people do community-led monitoring and it uncovers shortfalls, you can go to your country and say, well, we are already recommending this. The health authorities here recommend this, and WHO recommends it. So they're great support for advocacy. And last, what are the questions that need to be asked to make sure we're not just seeing if people are collecting samples? Is HIV testing available? And if so, where? Can people get are there self-testing options? Are people who get a positive HIV test result immediately connected to care? Are people living with HIV getting CD4 cell counts? And if so, when are they getting them? Are they getting information about why a CD4 cell count is done and what the results mean? When do they get results? Are people with a CD4 cell count that's under 200 getting the special package of care for AHD? That can be a matter of life or death. It's very important. Are people living with HIV getting viral load testing at 6 and 12 months after starting ART and then annually? Do they get the information about why a viral load is done and what the results mean? How long do they wait for the results? Are people with a detectable viral load that's unsuppressed provided with retesting, enhanced adherence support, and if indicated, different HIV treatment? And if they're not, what's the point of doing a viral load test? If you're doing it to identify treatment failure and reach people, if you're just doing the test and no one gets the results or they never switch treatment, there's no purpose. So these things are really important. Are they getting them at the right time point? And are people living with HIV getting screened for TB at every visit to a healthcare facility? And are people who screen positive getting further testing for TB, preventive treatment, or treatment for active TB? These are all the questions that sort of fill out the gaps in the cascade. And I thank you very much. That's the end of my presentation.
Thank you so much, Tracy. A lot of useful information, setting the stage for exactly what CLM for labs monitored during the course of 2025 and the role that diagnostics plays not only in diagnosing HIV, but most importantly, monitoring HIV care. With that said, I would like to continue. Uh, I'd like to continue this session on the country findings, in which I will provide an overview of the country findings, followed by, or this overall summary of findings, followed by the specific country partners who will provide their findings, as well as the monitoring the impact of the funding cuts and key takeaway. So before I get into the interesting bits, I would like to introduce ITPC and explain a little bit more about what we do, including our partners. So ITPC was born in 2003 in Cape Town, South Africa, by a committed group of 125 HIV activists from 65 countries who refused to accept a world in which people living with HIV were denied access to life-saving medicine. Today, we celebrate 22 years, highlighting progress in the fight for equitable access to and affordability of treatment. With that, I would also like to acknowledge the support from the African Society for Laboratory Medicine, ASLM, through its Laboratory System Strengthening Community of Practice, who has made this project possible and supported this project, even though we had experienced shifts in the funding landscape since the announcement of the US funding cuts in late January 2025. Our three partners that were involved in the implementation is NETIPS, who is a key stakeholder and umbrella organization for people living with HIV in Sierra Leone. The Democratic Republic of Congo, DRC, UCO Plus, was also involved with the implementation of the CLM for Labs, who's a non-profit organization created in May 2007 to coordinate the activities of PLHIV in all provinces within DRC. Lastly, I would like to introduce RAM in Burkina Faso, who is a civil society organization focused on improving access to quality health services and medicines for all populations. we have spoken a lot about what CLM is, community-led monitoring, and would like to take a few minutes just to define ITPC CLM model. ITPC CLM model is defined as a science-based accountability innovation that puts communities first. It covers 4 key areas, which is education, evidence, engagement, and advocacy. Overall, it is a process where communities take the lead to routinely monitor issues that matter to them. It is grounded in education and based on human rights, including the right to health, to ensure that all people are aware of the standard of care they are entitled to receive as per the World Health Organization guidelines for prevention, testing, care, and treatment for HIV, TB, COVID-19, viral hepatitis, and other relevant conditions. CLM is community-driven and increases accountability for and improves outcomes of national and local HIV programs and the health of community members. So the CLM for Labs project was informed and relied on outcomes that will identify gaps in order to improve access to HIV diagnostic and laboratory services. Access to viral load testing and CD4 count specifically is critical for people living with HIV on antiretroviral treatment. HIV-related diagnostics are essential for managing treatment and achieving positive health outcomes. In 2022, a pilot was conducted where community-led monitoring was implemented to monitor routine viral load and CD4 cell count testing across Kenya and Sierra Leone. The purpose of this pilot was to identify gaps in the availability of viral load and CD4 testing, including adapting the CLM model to access the impact of COVID-19. In 2025, which was last year, we extended the CLM implementation to two additional countries, which is Burkina Faso and DRC, and focused on continuing to address the gaps beyond the viral load cascade and CD4 testing, including TB screening and focusing on adapting the CLM model to assess the impact of the US funding cuts on HIV testing and early infant diagnosis. The objectives of this project in 2005 or implementation was to monitor availability and accessibility of TB screening, HIV, and CD4 cell count testing, monitor availability and accessibility of HIV testing and infant diagnosis, demonstrate any impact of the 2025 US funding cuts on the provision of these services. Most importantly, use the CLM data to show how communities can drive change to advocate for improved laboratory efficiencies. The methodology we followed is closely aligned with the model of CLM. We first conducted a desk review as well as a review of local framework and guidelines and capacity building on HIV diagnostic informed the choice of indicators co-developed by communities. We trained 60 community data collectors on the objective and use of the framework. The rollout was occurred retrospectively for the period of 1 July 2024 to 30th June 2025. 34 health facilities were monitored, 18 of which 18 were US funded sites, 16 non-funded US sites. 59 interviews were conducted with healthcare personnel and feedback was obtained by 481 recipients of care. We used a method of collecting data via a paper-based as well as an electronic version known as Alchema. ITPC, supported by LabCoP and LabMap initiatives by ASLM, provided the framework and guidance for the implementation of this project. This is a quick snapshot of the tool. As you can see, we focused on monitoring various diagnostic tests, which includes HIV testing, where self-testing became was a component of monitoring, early infant diagnosis, CD4 cell count, viral load testing, as well as TB screening, using community data to drive change. Overall, there were 63,768 HIV tests that were performed. 19,159 HIV tests were performed in Burkina Faso, with a stable volume between 4.5 and 5,000 tests per quarter. DRC performed 12,945 HIV tests after a 28% drop from 4,123 between July to September 2024 to 2,985 between October to December in 2024. Testing volumes remain stable in 2025 at around 2,900 tests per quarter. Sierra Leone performed 31,664 HIV tests, with an average of 7,540 tests per quarter in 2024, increasing to an average of 8,290 tests per quarter in 2005. Okay, I don't know what happened here, but anyways, let me just reshare. Okay, so HIV self-testing. A low uptake, the graph clearly shows that HIV self-testing levels, which are the dotted lines, are much more lower than standard HIV testing. Variations in the levels of HIV testing are mainly due to the availability of test kits. Burkina Faso, 42% or 50%, 5 out of 10 in the DRC, and 42% in Sierra Leone do not offer HIV testing. Barriers to HIV testing was identified as stockout self-test kits and a common perception that self-testing belongs exclusively under community outreach rather than under facility-based services. For early infant diagnosis, while data collected does not point any major dysfunction in early diagnosis of HIV amongst infants born to mothers living with HIV, the section on equipment malfunctions highlights that the reported cases of malfunction for equipment required for the nucleic acidic amplification test are often long-term, which means sites can be missing out infants in need of ARV treatment. The US funding cuts in DRC have also caused stockouts of pediatric ARVs, which further complicates the proper ART. All health sites in Sierra Leone and Burkina Faso declare performing point-of-care early infant tests at birth, at first contact, or between 4 to 6 weeks from birth, compared to 70% in DRC. The overall findings, which focus on CD4 cell counts, shows that across the 34 facilities monitored, 65, which is 23 out of the 34 facilities across the 3 countries, offer CD4 cell count testing, and 73% of them, 16 out of the 22, have point-of-care facilities. CD4 cell count testing is under-prioritized, especially in Burkina Faso and the DRC, undermining the continuity of advanced HIV care. In terms of viral load testing, we found that across all countries, which is 88% of the monitored health facilities, provide viral load monitoring. All 12 health facilities in Burkina Faso and all 12 facilities in Sierra Leone provide viral load monitoring either on-site or through sample referral systems. In DRC, 6 out of the 10 facilities accessed or assessed offer viral load monitoring in five primary healthcare sites and one district hospital. Lastly, TB screening. 54% of recipients of care confirm that they ask TB screening questions at every other healthcare visit, highest being reported in Burkina Faso with a total of 70%. 481 recipients of care were interviewed on TB screening to find out if their healthcare provider was routinely asking the WHO recommended 4 symptom screening questions on cough, fever, weight loss, or night sweats. 42% of respondents report that TB screening questions are never, rarely, or only sometimes asked. Highest rates are in DRC, 45%, and Sierra Leone, 53%. Lastly, the barriers to stockouts and equipment malfunctions. Stockouts were reported as systemic across the region, revealing fragile procurement and logistic systems. DRC faces the most acute and prolonged supply gaps due to structural failure of both Global Fund and PEPFAR distribution channels. Burkina Faso experiences recurrent reagent shortages and machine downtime due to administrative delays and incomplete supplies, while Sierra Leone shows better continuity but remains vulnerable to procurement delays and machine failure, especially in terms of HIV testing. So what was one of the main outcomes or impacts of this project, focusing on the achievements as well as reflections? So in terms of the reflections and recommendations in summary, firstly, since the announcement of the US funding cuts in late January, on the 29th of January last year, it did expose donor dependence for core functions and exacerbated existing fragile procurement systems. The recommendation is to institutionalize national procurement budgets and mechanisms to reduce donor dependency. Stockouts and equipment malfunctions are the main disruptors of diagnostic and laboratory service continuity. The recommendation is to strengthen national supply chains and maintenance systems to end recurrent stockouts. Results from the viral load monitoring are delayed and clinical management is weak. Findings suggest that in order to resolve the delayed turnaround time for viral load monitoring and clinical management, we need to strengthen viral load result management and clinical follow-up systems. In order to strengthen viral load monitoring, we need to reprioritize CD4 testing to strengthen advanced HIV disease management. Community-led monitoring revealed gaps across the diagnostic cascade that are not captured by routine national monitoring system. In summary, communities remain as the first responders despite any changes or shifts in the health system. It is important to consider that now there should be a shift and change and move towards institutionalizing CLM in national monitoring systems and ensuring strong community engagement in the design, implementation, and monitoring of laboratory services. I would like to thank everyone for their time and for attending this webinar. Specific thank you once again to ASLM as well as our partners. I would also like to say that we did present the preliminary results of the CLM for Labs implementation at the 8th annual LabCoP meeting, which took place in Kenya, Nairobi, between the 22nd to the 24th of October in 2025. To know more about our ITPC's work on CLM, please do. I will copy and paste this URL onto the chat if you need to access more information, and most importantly, if you need to access the final report on which is titled Community Data in Action, Community-Led Monitoring to Improve Diagnostic and Laboratory Services. With that, I would like to say to you, thank you for your time. And I would like to now hand you over to Anj Mavula from the DRC.
So
Oui,
I
c'est
think
bon,
that you can
c'est
see
bon,
it.
mais mets-toi en full
Yes,
slide.
yes,
On voit.
we can see it. Just yeah, put in full presentation
Oui,
mode
c'est
is
bon.
good, right?
Oui,
That's all right.
on
That's good.
arrive bien à voir votre présentation, pas de problème.
Oui, oui, on voit Ange, c'est bon.
Yes, we can see it. Yes, I think that you can also hear me because I'm speaking French. I hope that the interpretation is working.
On vous entend très bien, monsieur Ange, vous pouvez parler français, pas de problème.
Oui.
Can you hear me?
On t'entend.
This is the case study of the Republic of the Democratic Republic of Congo. So the country context is something that I should mention. We had a drastic reduction in international resources for the fight against HIV, and a strong dependency of the DRC on external funding for the fight against HIV, about 90% from the Global Fund and from PEPFAR. Now, we also had poor access. We suffered from poor access to viral load and other laboratory tests for PLHIV. And in this context as well, we had the suspension of US funding. Now, the key findings of this report shows us that since 2024 till 2025, there were about 15,176 patients with HIV that were admitted for testing, and so living with HIV eligible for VL tests. Then we had about 13,580, which was the number of people living with HIV who have received a VL test. 7,309 were living with HIV who received their VL tests results in 2 weeks after taking the test, and 5,287 living with HIV which had blood samples taken for VL tests, but results were never done or were never made available. We had 188 people living with HIV who had a detectable viral charge, viral load, and 122 people who were living with HIV who received improved adhesion advice and repeat VL tests after 3 months, and 7 living with HIV had changed ART. Now, we then look at 6 out of 10 facilities monitoring the viral load. We had 5 of these which are funded by the at the time by the United States, including 5 primary healthcare centers and 1 hospital district. And following funding cuts, the number of viral load tests fell by 69% from 10,321 between July and December 2024 to 3,219 between January and June 2025. Now, In DRC, 121 infants were born to HIV-positive mothers, and 79 NAAT tests were performed during the same period. Whilst these figures suggest early HIV diagnosis services for infants are functional, the gap between the number of births and the number of tests reveals gaps in screening coverage. Recurring stockouts of EID test kits and reagents, as well as irregular deliveries from the central level, were observed, and a report, which is the Light Polyclinic Health Center, by the Light Polyclinic Health Center, indicates delays of up to 6 months in receiving results from the reference laboratories. Key findings: the report shows that the DRC faces a significant proportion of people tested for viral load which never received their results. EID results can take up to 6 months, as I've mentioned, and some shortages last more than a year, preventing health facilities from complying with national and WHO standards. Detectable viral loads are not systemically monitored, and clinical documentation is very poor. Now, the impact and monitoring. The impact of US funding cuts was prolonged stockouts of reagents and consumables. We also had a suspension or delay, if you will, of laboratory activities such as HIV testing, CD4, and viral load. Decrease also in a huge decrease as well in financial incentives for service providers. We also had extreme dependency issues. The majority of services, CD4, EID, VL, are contracted in US funded sites. And after the cuts, the 69% drop in volume of the viral load tests was observed from as I mentioned, from 10,221 to 3,219. So here you can see an example. I think that you can see how this all started in June, and we can see here that DRC 60% or 6 out of 10 of third tests, that's the orange line at the bottom, encountered shortages of or at least due to and to be honest, the confirmation which could not be carried out due to the prolonged stockouts. So now here we have the advocacy successes that we've had. So thanks to the pressure exerted by the implementing partner and civil society partners, the following results were achieved. Firstly, a national emergency workshop on supply was organized, during which a national supply and distribution chain was developed. The recruitment of sample transporters was initiated, and regular meetings between public relations, PNLS, and civil society were established to monitor stockout issues, and as well as finally a training of healthcare professionals in viral load monitoring has begun at this point. Now, in terms of key lessons, the DRC's dependence on external partners makes the HIV diagnosis and laboratory system extremely fragile, and US funding cuts have revealed the extent of this fragility. The 2025 cuts showed that without external support, much of the systems grind to a halt. Stock shortages, suspensions of activities, delays in results, decline in service quality, and the sustainable solution, we believe, lies in mobilizing domestic resources, which is something that we are looking into at the moment. And that is something that we should think of, especially with the keyword being sustainable solutions. Now, in terms of concluding remarks, the DRC must strengthen its health sovereignty by taking charge of HIV input management, stabilizing the supply chain, rehabilitating CD4 services, and improving results management. The CLM has proven its usefulness in revealing dysfunctions and guiding decisions. the commitments obtained through advocacy must now be consolidated to ensure the community of viral services for people living with HIV. And we believe that that is very important. Now, in closing, I would like to thank you so much for your attention.
Merci beaucoup, Ange. Tu es là, are you here, Pragashni?
Thank you so much,
Oh, I
Ange.
can continue. Thank you very much, Ange, for this. There is quite a lot of question on DRC on the chat, Ange, if you want to answer, to explain the specific context of DRC. So thank you again. So Pragashni, I think the next presenter is Sierra Leone, right?
It is Christian Nissan from
Christian.
Burkina Faso.
Burkina Faso. Ok. Ok, Christian. Est-ce que tu es avec nous?
So, Christian, are you with
Est-ce que
us?
tu peux projeter tes slides?
And can you please share your slides?
Merci bien, merci à
Okay, thank you
Le
so
temps de
much.
projeter. Voilà.
There we go. Just give me one moment to share the slides.
Ok. J'espère que vous voyez mon écran.
I hope
Oui.
that you can see my screen.
D'accord. Donc,
Mets-toi, essaie de
Yes.
te mettre
Okay,
en plein
so
écran, tu sais, en
try and
bas.
put it in
Voilà.
presentation mode,
Voilà,
full
super.
screen mode, please.
c'est bon.
That would be helpful. Yes, there we go.
Ok, je peux aller là, c'est bon?
All right,
C'est
can
bon.
I go for it?
Ok, merci bien.
Yes, that's fine.
Alors,
Perfect.
en
Thank you
ce
so
qui
much.
concerne le Burkina
All right,
Faso, il
so
faut dire que
with regards to the country
de façon
context
spécifique,
of
parler de
Burkina
il y a
Faso,
genre plusieurs problématiques au Burkina Faso. Comme vous le voyez,
we
donc,
have HIV remains a
elle aurait
public health issue in
donc
Burkina Faso. So
déchiffré au
national
niveau des fil attendants
prevalence of
en 2023 et
0.6%
2024.
in 2024
39
of
794
ASLMS. We have
corps.
cumulative
Et il faut dire
activities,
qu'il y a un taux de réalisation de la
active
charge virale
caseload
en date de
of
2024, selon donc l'année statistique du ministère de la Santé, qui est de
69,53
56,33%. Comme vous le savez, nous avons
PLHIV
fait
in
les 100% et
2023
nous
and
ne pouvons pas rester donc dans ce réseau-là
80,739 as
pour atteindre donc
according
le
to
troisième
2024.
95
So the
et
CV
alors,
achievement
autour
rate
donc
is
de cette lutte
66
contre le
point
VIH, les autorités sanitaires donc, du ministère de la Santé est accompagné donc par le programme
is about
et effectivement donc par l'application de la
66.35%
lutte contre la maladie et également
from what
donc
we observed
par
in 2024, which
l'ADSM
remains
modèle
low
donc
given
contre
the rapid
laboratoire.
progress towards the
Et bien sûr,
desired
la société civile
third
donc accompagne le
95
ministère dans cette lutte,
or the
notamment avec
95
l'immunité
95
également donc
95 by 2023.
le RAM
This
donc avec l'ensemble
is
des
despite
sociétés
the efforts
ou le
made
CLM
by
ou
the
CAS ou en
authorities
tout cas avec le
such as
suivi également. Alors, il faut
PSSLS,
dire aussi que
DLBM,
au Burkina Faso, la particularité, c'est
SPCNLS,
que l'énumération syndicale donc sur
DGAP,
2016 environ, voilà, à
CAMEEG,
partir que
and with
pratiquement au
the
lycée,
essential
le
role
protocole
of
est entré
the
plus ou moins en
SC
jeu.
and
Donc, il y
communities
a
as well
un
as
an,
community
et ça n'a
monitoring.
pas été donc effectif
And so,
au niveau
however,
systématique par
CD4 count
l'application
is no
et
longer
système.
systematic
Mais
with
en tout cas,
the application
selon donc
of
l'objectif, donc,
the
et
test
ça a été
and
donc
treat
légué
protocol
au
since
second plan et qui le fait toujours. Alors
2016.
donc, il faut aussi dire que
So we also have to
depuis
say that
2003,
since
l'armée
2003,
donc américaine donc
the US
le plan PEPFAR
supports
appuie
PEPFAR since 2003 in health
différentes
centers
formations sanitaires
in 70
au
health
donc Burkina Faso.
districts
Voilà une trentaine donc dans les provinces
was
du
a
Burkina
huge
Faso. Donc un
help.
appui considérable
But
qui vraiment appuyé la lutte
now we do
contre le
not have the
VIH
support
qui date
anymore,
depuis 2003.
and that is a
Maintenant,
major blow.
à
Now,
travers donc
in
ce suivi dirigé par vous,
terms
lequel nous avons
of
l'honneur donc
the
de conduire cette expérience avec
we still use
l'accompagnement
these
donc de
experiences
ITPC et ses partenaires.
and the
Quelles
knowledge
sont
that
les
we had
contributions que
to
nous
work with
avons
our
pu
partners.
aboutir? Alors, il
And
faut
now,
dire qu'au
what are the
Burkina
main
Faso,
conclusions that we
comme
were
l'a bien
able
dit
to
tantôt,
come
voilà,
to?
donc
Was that we
nous
have
avons
coverage
pu
in
en tout
10
cas
regions.
toucher 10 régions donc, au Burkina
So we
Faso,
do have
dont
coverage, and we
12
were able
districts
to reach
sanitaires.
10 regions. We
Et
have
on a
12
12
DS,
formations sanitaires, 12
um,
établissements de santé que
so
nous avons
so
visités.
so
Parmi ces 12 établissements de
so
santé, il y a ou
12
bien nous avons 7 qui
sanitary
sont donc des sites
trainings,
PEPFAR, donc appuyés,
um,
qui étaient appuyés par
and they
le
were,
financement américain
as
et
well as
5 plans
12
PEPFAR. Et donc, nous avons
FSs,
pu
which
intervenir
were
et échanger avec
7
donc
supported
52
by
cas de
PEPFAR
VIH,
and 5
donc
non-PEPFAR
notifiés, on va
supported,
dire, dans ces services-là.
152
Et
PL-HIV,
37 prestataires de soins nous ont
and
accompagnés donc dans
37
l'accompagnement.
healthcare
Voilà.
providers as well. So
Alors,
that's now
toujours les principales conclusions en termes
now
donc
still
de
with the
dépistage
main
pour la co-infection
conclusions
tuberculose.
or,
À ce niveau, il faut dire que la co-infection,
results
la prise en
or
charge
key
de la
findings
co-infection est
is
effective
that
rapidement
TB co-infection
et avec
screening,
le retour donc nous avons 95,39%
firstly,
donc
HIV
des
TB
bénéficiaires donc
co-infection
qui ont déclaré
treatment is
être
effective.
suivis, en tout cas
95.39%
pour
of
en tout cas
PL-HIV reported,
ce dépistage continue donc
which
sur
have
la
been reported,
co-infection VIH.
being monitored for
Alors
this.
malheureusement, nous avons
However, a
aussi
significant
une
number of
proportion qui n'est pas exploitée,
PL-HIV,
qui a subi cet manque de connaissances donc
including
sur donc les
CHUY,
symptômes de tuberculose
CHUCG,
dans le cadre de la comorbidité
CHUSS,
qui revient donc dans
expressed
les
a lack
données.
of knowledge about
Notamment certains sites,
tuberculosis and
grands sites comme
comorbidity. Testimonials reveal that monitoring is sometimes
alors il faut dire que
irregular
les témoignages donc
and
révèlent donc que le suivi n'est pas parfois
depends
régulier
on the
pour la
initiative
co-infection
of
et
the health
cela dépend
worker.
donc
So
de
it is not
l'état donc des
always
cas de TB selon le
systematic
retour.
at certain
Donc
levels.
cela n'est donc pas toujours systématique à certains niveaux. Donc c'est un peu ça un
So
peu le défi.
that
Donc,
is a little bit the
sensibilisation,
challenge that
donc
we
la prise
face
en charge de la
in one way
co-infection
or
est
another.
systématique selon les
Now
directives au Burkina Faso doit être
there is no
appliquée donc sur toute
there is
consommation
no
sanitaire.
real
Alors donc
framework
pour la pour le
now
CD4, la numération CD4, comme je vous disais
for
tantôt, hein,
CD4 testing
voilà donc
services. In terms of
il faut
main
dire que
or key
étant
findings,
donné que
we have
la
found
numération
that
CD4
CD4 is not well
depuis
known
l'année 2003
among
avec
beneficiaries,
des
although
tentatives de mesure systématique
66.48%
et
of
dans les
the
centres,
152
en tout cas le
beneficiaries
nombre donc de
surveyed
formations
know
de
what
PEVH
the
que nous
test
avons
is.
interrogées, bien
33.52%
sûr, et plus de 70%
say
donc
they
pensent
do
que ce
not
produit
know
effectivement,
or think
ils ont eu
that
à
it is
étudier
no
donc
longer
qu'est-ce donc
practiced. In fact,
la numération charge
CD4
au
counts
CD4.
are no longer
Et
systematic,
malheureusement,
with
selon eux,
the
environ
application
33
of
qui ont déclaré
the
ne pas
test
avoir
and
donc
treat protocol,
cette
resulting
information.
in
Mais le plus souvent, les 33
inconsistent
PEVH, les
practices
33%
between
sont beaucoup plus les
sites.
nouveaux
Among
qui ont été donc,
PL-HIV
ils ont été
who
infectés et
have
qui sont suivis
received a
depuis
CD4
lors.
count
Voilà
result,
donc,
which is around
et comme je
73%,
disais, la charge
in
virale donc
the
n'est pas
past,
systématique
said they
selon
had
l'application donc
received
du protocole.
explanations
À
about
partir du
its
moment
meaning,
donc nous sommes à la phase de
or at
test
least a
introductive.
definition,
Et donc, ce
and
qui fait qu'il y a une hétérogénéité des
13.35%
pratiques dans
said
les sites. Il
they
y a
had
certains
made
sites où
additional
ça se
visits
poursuit, d'autres sites
to
où
obtain their
ça ne se fait
results,
plus. Dans les
i.e.,
sites où
in other words,
la
not
numération CD4 se
routinely.
poursuit,
Now
l'outillage, la documentation n'est plus aussi donc
that
comme il
is
se devait par le passé. Voilà, donc c'est un peu ça.
so
Et
that
on
is
a remarqué que
basically
cela se
the
fait donc
situation there,
beaucoup
and
plus dans les
we
centres
found that
universitaires. Dans les plus de centres
it
universitaires
fell
que la
upon
numération CD4
the
sert davantage.
universities and
Alors donc,
researchers to do
parmi
that
donc
work.
ceux qui ont eu
Now
à faire la numération charge virale, parmi cette cohorte-là, il faut dire que 73% ont dit avoir reçu donc des explications sur sa signification.
we
Et donc,
also try to increase
l'autre proportion donc
since
effectivement n'a pas donc cette
I would say
information donc systématique.
knowledge across
Alors donc,
our
pour la
communities.
charge virale au Burkina Faso, la
And
charge virale est un suivi biologique
now, with
normal
regards to
et
viral
très
load
intégré donc
service
qui prend en compte au
provisions,
Burkina Faso.
um,
Voilà.
viral
Et nous
load
avons donc
is
près de
better
94%
integrated
donc
into the care
des
of
bénéficiaires qui ont
PL-HIV.
affirmé effectivement
So,
de ce suivi de charge virale à des périodes
however,
à la
6%
périodicité
of
donc comme
PL-HIV
indiqué dans
stated
les
that
directives.
they were
Mais nous
unaware
avons
of
croisé certains
the
PVH
viral load
aussi qui
tests,
n'ont pas donc de cette
highlighting a
information
need
et
for
ceux-là.
improved
Donc nous pensons
patient
qu'à ce
counseling.
niveau,
Access
la
to
question
viral
donc du
load
controlling
results
des patients en isolation de
included more
ventilation
than
doit se
2 weeks
poursuivre. Également,
or for 41%, or even
on
3
a
months
pratiquement
for
41% donc des
PL-HIV.
bénéficiaires qui ont
These
affirmé oui,
delays can be
effectivement,
explained
les
by
résultats ont été
challenges with the
obtenus donc plus de
availability
deux
of
semaines après,
supplies and the
ou en tout cas 3
functionality of
semaines
the
après donc,
devices, and
et donc la
11%
réalisation donc de la charge
represents a
virale. Donc
specific
nous avons un
medical
retard donc dans la remise
consultation
donc
or
des résultats.
appointment
Cela
to
s'explique
obtain their results.
par
Now,
le défi donc de disponibilité donc
officially,
des intrants et la
uh,
fonctionnalité des appareils.
viral
Donc on a
load
écouté
tests
donc
are
les
free, so
responsables des prestataires de
persistence
soins
of
qui nous ont donné donc
financial
des
and
informations pour les
geographical
recruter. Et donc,
barriers,
également, il faut dire que
15%
la gratuité donc, de la
difficulty
charge
with
virale est
indirect
actuellement au
costs,
Burkina Faso.
transport,
Voilà.
including
Mais
transport, meals or
il faut
parking,
dire que
and
malheureusement,
accessibility barriers such
et,
as distance and laboratory opening hours
voilà,
are as well
malheureusement,
challenges.
nous avons encore toujours des
Unfortunately,
obstacles financiers et
we
géographiques
still
à ce
have
niveau.
those
Voilà, par exemple,
financial
15% donc
difficulties
des
and
bénéficiaires
obstacles.
ont carrément
Um,
déclaré avoir fait des cours
the
exprès de
beneficiaries
transport
have
sur le repas
declared
ou
again that
stationnement qui
the
peut souvent
transport, the meals, the
décourager
parking,
les
as I mentioned,
usagers à venir
are a
vers
problem.
pour arriver à faire le
And
suivi donc des examens et pour la prise en charge.
we could
Certains
say
même
also
des
that
obstacles aussi lié donc à l'horaire donc de certains
even though it
laboratoires.
is free,
Certains laboratoires souvent qui ouvrent en
some
retard de certains
PLHIV
maladies, souvent les laboratoires ne font pas
patients
suffisamment
have
efficacement
stated that they paid
les
directly
dépistages
for the
et souvent les
tests that
transports
they
donc des samples
were
donc vers ces laboratoires ne sont
um,
souvent pas
that
respectés
they
par
had done to
certains
them.
usagers.
So
Voilà, donc les paiements donc directs aussi sont monnaie courante. C'est des cas que nous suivons très souvent et que
that's
nous expliquons
a
donc aux
case that we're
autorités.
busy
Voilà,
following
par exemple,
very
ce cas,
closely, the
pour
payment
cette expérience que
for
nous avons
tests,
vécue, il y a droit également
because
de
it's not
payer avec
supposed to be
plusieurs
that way.
fois
It
donc des
was
coûts
three, I
pour
think that it was three
rentrer dans la
patients that had
procédure
mentioned that.
du testing.
So
Alors donc, en
now,
question
in
donc pour
terms
la
of
disponibilité donc
availability
des
of
appareils,
inputs
à ce niveau,
and
hein,
devices,
et sur tous les sites que nous
um,
avons visités, 100% des sites ont déclaré avoir eu donc
100% of
des
the
effets donc
sites
de
visited
retard
experienced
et donc
reagent shortages
refus donc
over a
de
period
réactivité à leur
of
niveau.
5
Et
to
ces refus-là,
365 days due
d'une
to
formation sanitaire à une autre,
lack of
varient donc
products,
de 5%,
unfulfilled
de
orders,
5
orders
jours à
delays,
365 jours. Donc, quand vous voyez les
lack of
365 jours, ça veut dire
funding,
que nous avons des sites
and
qui, malheureusement, ils ont
slow
fonctionné toute
administrative
l'année
procedures.
sans pouvoir faire
So
fonctionner leur machine.
365 days
Voilà le
represents
procès,
pretty much an
quelques
entire
patients.
year
Et quand
and
on
day.
va croiser
So
l'information auprès des prestataires
when
pour savoir quelles étaient les raisons,
we
beaucoup
then
plus
ask
se sont
for the
prononcés
reasons for these
sur
delays,
le manque de
um,
produits et les
is
commandes
it
donc
comes back to
insuffisantes,
the lack
le retard
of
donc de commandes, l'absence
products,
donc de
and
livraison, la lenteur également donc
um,
dans la procédure donc
all of that
administrative
starts
donc
to then have an
étaient
impact
donc
on
les
the
raisons
slowness
souvent donc de la
of
coupure et des réactifs auprès donc des formations sanitaires visitées.
of
Et plus de
obtaining
50%
reagents.
effectivement ont connu donc
So
des problèmes donc de fonctionnement donc de ces
then we also
appareils.
found that more than
Et
50%
les
of the sites
problèmes de
visited
fonctionnement vont de
experienced
7 à
equipment
365 jours.
malfunction
Comme je
over
disais tantôt, il
7
y a
to
certaines formations sanitaires dont les
365 days,
appareils ne peuvent
again
fonctionner
due
pendant
to
plus
lack
longtemps.
of
Voilà. Et il y a certains
inventors,
effets donc
insufficient
de stop
maintenance, memory
et
card
voilà, quelques
problems,
à plusieurs
lack
jours de
of
fonctionnement.
cartridges,
Également
air
là-bas, quand vous
conditioning
écoutez donc le
failure,
retour donc du
and
suivi communautaire,
slow
c'est
administrative
par exemple
procedures.
le manque donc
So
du matériel nécessaire pour le bon fonctionnement donc
again, it's all up to the equipment that
GNSPR,
is
des ondes
necessary
de Cubase, et tout ça de ces appareils. Par exemple,
and the reagents that are
l'absence par exemple
necessary
de
to
ventilateur
perform all these
et le
tests.
manque donc de
And
climatisation donc de la salle donc de laboratoire peut créer un
the
problème.
also when it
Mais
comes
pour
to the air
certains, c'est
conditioning,
donc le matériel
that is a
efficace
huge
qui ne
thing
peut
as
pas donc
well
être.
in
Voilà.
terms of
L'absence de
keeping
cartouches et la
samples
lenteur souvent donc dans la
in the
procédure
right
donc administrative
conditions
pour des
for
questions donc
testing
de
and so on.
maintenance, ils ont été donc
So
les principaux donc problèmes
and a huge problem
rencontrés.
as well as the maintenance. I would just
Alors,
like to highlight.
et
Now the
l'impact donc
impact monitoring in
de
terms
la
of
réduction donc
funding
du financement en
reductions in
2025.
2025.
Comme je vous disais tantôt,
Like I said
l'ensemble des sites
above,
que nous avons visités,
four
voilà, et nous avons
out of the
4
seven sites
sur 7
that
sites visités qui
we
ont signalé
visited,
vraiment cet
the
impact.
PEPFAR
Parce que les
sites
formations
visited
santé que nous avons
reported
visitées
impact.
n'ont pas
So
effectivement fait
Yalgado
cette évaluation
University Hospital,
publique pour nous donner des
there was a
informations, mais il y a
dissatisfaction
4 au
with
moins qui se sont
the
prononcés sur cela.
compliance
Quand on
of
prend donc le
input
centre
orders.
universitaire Yalgado, cela s'exprime par quoi?
Reagents
La
received since
non-satisfaction
then
donc
are
sur
not
les commandes,
suitable for the
sur la
analysis
conformité à la commande.
equipment.
C'est-à-dire désormais, après la coupure,
And even after
les réactifs
the
qui devaient
funding
parvenir
cut,
souvent n'étaient pas
the
conformes au
reagents
matériel qu'ils avaient
were
parce que
not
peut-être c'était d'autres partenaires donc qui
in
pouvaient
line with
exécuter
what they had
l'effort.
ordered.
Également, nous avons
So
donc cette
we
inadaptation donc
also had,
des appareils d'analyse
to
et
adapt
pour les
the
réactifs nucléaires. Quand on
analysis
prend la flash nucléaire, par
equipment.
exemple, le personnel
And
effectivement a connu donc une absence donc
again, then you
ou
have a problem with the
une de
staff
motivation pour certaines tâches,
morale that is low,
ce qui a
and
créé
that is
donc
what happened also at Kea
une baisse
Regional
donc
Hospital. So staff morale was low,
de
a
motivation
lack
bien
of
sûr.
motivation due
À
to the
Koudougou,
bonuses
ils se
for
sont
certain
prononcés
staff
carrément sur
members
le fait
only.
que la
Uh,
fréquence donc des
Kudugu
ruptures des
Regional
réactifs
Hospital
a
Center,
nettement
also
augmenté
experienced
depuis
the
donc le
frequency of
couvre-feu.
reagent
Voilà.
shortages, which had
Maintenant, pour un
increased.
cas
And
exceptionnel, par exemple,
Fada
ici à celle de
Regional
Fada qu'on a bien
Hospital,
présenté, après un
uh,
site
which was
non PEPFAR, selon
non-PEPFAR,
certains sites qui n'étaient pas
it's a
appelés donc
non-PEPFAR
par
funded
directement
site.
donc par
They were
l'État ministère,
impacted by
mais par
the
ricochet,
considerable
nous avions
reduction
des
in
ONG, des associations qui intervenaient
interventions
donc dans ces
by
sites-là
NGOs
pour
and
appeler, en
associations.
tout cas,
So
au
awareness
retardement
raising
d'effort
is
pour
an
les
issue.
questions donc
Active
de
research
sensibilisation, pour les
became
questions
an
donc
issue,
de
and
recherche
index
active et
cases
pour les cas index.
became an
Donc, toutes
issue,
ces ONG, ces associations qui
among
se sont
other
donc
things as well.
appuyées avec ce coupure ont freiné leur
So
action, ce qui donc a impacté le travail donc de
that
l'établissement
impacted,
pour les questions donc de
a lot
suivi
of the work of
communautaire.
the establishments in
Alors,
place.
qu'est-ce qu'on peut dire donc du
So
succès donc de plaidoyer? On a
what
fait un
are
diagnostic
we
là.
looking at in terms of
Alors,
advocacy success?
après donc les données
We
donc recueillies au
have,
niveau donc du suivi
after the data
communautaire,
that we received of
nous
all
avons
of
pu
this,
mener
we
donc une
had,
action de un
we
plan
were
de
able
plaidoyer qui nous a
to
permis donc,
organize
un,
actions.
de former dans un
So
premier temps les
firstly,
acteurs locaux qui ont vu donc ces situations
to mobilize 36 local actors that were trained in terms of advocacy actions to engage with local authorities with a view to resolving locally identified problems. We had meetings to discuss findings, such as results, CHR in 10 Kodo. In 10 Dogo was supplied with 50% of PERT HIV and HIV-1 reagents, 4,800 HIV-1 reagents. Commitments were made by hospital administrators to avoid potential shortages as much as possible and to deal with delays in supplies from CAMG, MEG. On the 25th of August 2025, the Director General of the Fada Regional Hospital committed to finding alternatives to ensure the continuity of screening services, viral load, and he therefore suggested the RAME to form a united front within the SPCNLS. Now, from the 2nd to the 3rd of October 2025, the results were presented to the members of the CCMBF Strategic Monitoring Committee to advocate for the findings. At the national level, RAME issued a statement on all the malfunctions observed at the CNLS, DLBM, the DGAP, the CAMEG, the DSF, and the HIV and tuberculosis programs. Now, a national meeting on the 25th of September 2025 was held to disseminate results and distribute the report to the Ministry of Health, hospitals, and PTF. Now, we did all of this so that we could at least increase advocacy, we could increase advocacy actions, and also engage local communities and authorities more, and kind of bridge that gap between community and authorities. And that allowed the different involved actors to carry out their actions of engagement correctly and efficiently. Now, to be able to work specifically with, I'm sorry, the
Christian, il faut qu'on conclue un petit
I think we
peu
need
parce qu'il
to
y a encore
conclude.
d'autres présentations.
There's also a little bit of a issue with your sound, but we
Merci.
need to conclude, and there's another
Merci,
presentation
Christian.
coming up. So thank you so much, Christian. So there we go. So this allowed us to so the technical and financial support provided by the ITPC and its partners has enabled CLM OCAS to strengthen the community monitoring of diagnostic and laboratory services for HIV care. This initiative has identified both good practices and shortcomings in the care cascade, screening CD4 and viral load, with open dialogue between the authorities and the SC. So the results obtained now provide a solid basis for multi-sectoral advocacy actions aimed at accelerating progress towards achieving the 395 in the response to HIV in Burkina Faso. Thank you so much, Christian, for having detailed the situation in Burkina Faso. If you have any questions, please do not hesitate to put them in the chat or in the Q&A box if it is still there.
Thank you everyone for being here with us.
Go over to Martin Ellie from Sierra Leone, who will take you through to the findings from Sierra Leone. Over to you, Martin, and to please make, I know you have a little shorter time, but please bear with us with the time. Okay, Martin, can you hear me?
Yes, I can hear you, Pragashni, and thank you very much for accepting to share my slides. I will do my best to run through these slides quickly. So let's move on to the first slide. So for the country context, the HIV epidemic in Sierra Leone is generalized with an adult prevalence of approximately 1.7% among people aged 15 to 49 years, according to UNAIDS, and that diagnostic services, including viral load testing, early infant diagnosis, and quality management systems, have been decentralized with support from partners such as Global Fund and PEPFAR, strengthening access to laboratory services. National program data also indicate that about 76% of people living with HIV know their status. 76% of national population of 8,000 or 8 million, live with HIV in Sierra Leone, underscoring the continued need for intensified community mobilization and to expand testing efforts to close that remaining gap. However, systemic challenges still persist, particularly in ensuring supply chain continuity, efficient sample transport systems, and reduced turnaround times for test results, especially in rural communities or remote districts. Additionally, WHO indicates that the health sector financing in Sierra Leone is reliant on the out-of-pocket spending by households or service users, which account for more than 50% of the total health expenditure, posing barriers to equitable access to care. Let's move on to the next slide. So for the overall key findings, stockouts of supplies or commodities actually disrupted the continuity of testing services and limited the ability of health workers to provide timely diagnosis. Although recipients of care demonstrated knowledge or familiar with the diagnostic tests, about 66%, accounting for CD4 and 61% accounting for viral load. An average of 115 respondents identified access, mainly in terms of transport, to health facilities as a challenge. So while CD4 test results are usually provided the same day, viral load results often take between 2 weeks and 1 month, highlighting delays, particularly for viral load in treatment monitoring. Of the 12 health facilities we reached, 7 offer point of care testing for infants, improving early infant diagnostics coverage. Additionally, TB screening and provision of TPT or tuberculosis preventive therapy are integrated into routine HIV care services at health facilities. Next slide. So for CD4, the findings for CD4, all 12 facilities we reached provide CD4 testing, with over 80% of the recipients of care receiving their results on the same day, followed by counseling and related services, in line with the national treatment guidelines. And then the facilities also report continuity of care for about approximately 60% of recipients of care with CD4 count below 200, ensuring that clients with advanced HIV disease, if you like, receive follow-up services and then the necessary clinical support. Let's move on to the next slide. So for viral load testing, to run through this, for the timeline for which we did this work, starting from July 2024 to June 2025, 77% of recipients of care who were eligible at the 12 facilities covered received viral load tests. However, only 38% obtained their result within the 2 weeks, indicating delays in result turnaround. On that same note, while 69% reported that their viral load results were explained to them, 52% indicated that transport to these health facilities, remain a challenge for them. Let's move on to the other slide, Pragashni. So regarding the funding cuts, exactly. Regarding the funding cuts by the U.S. government, how it affected us. So the halting actually of stipends for volunteers and healthcare workers, it equally affected Sierra Leone. It weakened the morale of the healthcare workers and even the volunteers, affecting service delivery across the supported sites, PEPFAR supported site to be specific. So this decline in motivation disrupted the provision of life-saving services, including TB screening, AID, CD4 testing, viral load testing, ART refills, and it undermined the support systems that clients rely on for sustained engagement in HIV care. Although overall testing volumes, as we can see in Sierra Leone, remain relatively stable throughout 2024, we can see a notable shift emerge in the second quarter of 2025. US funded sites recorded a 15% decline in testing from 3,145 to 2,676. While on the other side, the non-US funded site experienced a slight increase of about 7% from 5,202 to 5,560, suggesting a potential link between the funding disruption or cuts and that of service provision or performance. Next slide. Regard for advocacy, out of the evidence that we generated, we identified or more or less focused on two, one being the systemic challenge of stockouts of supplies for HIV diagnosis. So for this one, we had an advocacy win, if you like. We had a big meeting, as you can see on the far right. We secured commitment from the Ministry of Health, to deal with this particular issue once and for all. For over the last decade, we've been struggling with stockouts. So they have agreed to tackle this once and for all. And then for test kits, self-test kits, inadequate supply and uptake of HIV self-test kit. For this, we could not secure any commitment to expand access, as it is largely focused on key population, including MSMs, female sex workers, or people at risk, high at risk. Next slide. Next slide, please. So for the key takeaways from this presentation, stockouts of test kits and supplies actually disrupted testing modalities and compromised the delivery of quality HIV services. And in addition, the US stop work order or funding cuts negatively affected the morale of people providing and supporting delivery of care at the health facilities. This disrupted the provision of care, as I indicated earlier, and the support system relied upon by the recipients of care. Also, transportation to health facilities continue to represent a key out-of-pocket expenditure, limiting equitable access to services. Finally, more efforts, are needed, particularly to improve turnaround time for viral load results to ensure timely clinical decision-making and effective treatment monitoring. Next slide, Pragashni. So for us to reflect, actually, for us natives as a community actor, a very key community actor here in Sierra Leone, the CLM for labs enabled us really to identify the impact of these funding cuts on the human resource for health, particularly at the US-funded facilities or sites, as well as the ripple effect on the quality of services they provided. Moreover, the findings further revealed that the recurrent stockouts of supplies and commodities remain a systemic challenge, constituting a critical advocacy priority, that requires high-level policy and administrative intervention by the Ministry of Health, which Natives is closely following up on. Possibly my last slide now. Move on. Yes, thank you. So, as part of my concluding remarks, to achieve the global benchmark, this is our view, by 2030, HIV testing services in Sierra Leone must be optimized through a client-centered approach that prioritizes accessibility, quality, and responsiveness to the needs of diverse population. And also community actors should play, including natives, and we have other CSOs here as well. They should play a consistent and proactive role in monitoring and following up on HIV testing services in order to strengthen accountability, improve service uptake, and accelerate progress toward epidemic control. I want to thank you very much for the opportunity to participate in this webinar, and thanks to ITPC and ASLM for the support. Thank you, and over to you, Pragashni.
Thank you, Martin, and thank you to the rest of the team. We have a few minutes for a Q&A session. Francis, I'm not sure whether you have enabled the chat, or we can look through some of the questions that have been asked. But overall, all the slides will be sent through to those that have registered for the webinar. And if there's any specific questions, please raise your hands and we will be able. So we have Peter. Okay, go ahead.
Yes, I'm very interested in understanding why CD4 is not being done in Burkina Faso, except I missed it in the presentation, but I kept hearing the presenter saying the country is just going with test and treat, and there is limited CD4 testing in the country. If that is true, how are they handling advanced HIV disease in the country?
Did you hear the question, Christian? So the question was on CD4 in Burkina Faso. Why is it not done? And how can you otherwise, detect? Thank you very much for this question. So it is not done systematically as it was done before. Otherwise, as mentioned, it is done definitely, but otherwise, when necessary, if it's really necessary from these zones, we can refer persons, but to other centers. But it is not done systematically as it was done before, and we didn't get the data exactly before. Oh, I'm sorry. And I said it is not systematically done. So you have also the university center or hospital, and we definitely refer people there in different regions. It is still done at this level. Thank you. I hope to have answered your question.
So there is Eric Okeyo and
It's
Do you want
Peter.
to? And Peter, yes.
Yeah.
Peter, if you want to go ahead.
Yes, good evening.
Good evening.
Yes, I'm Eric Okeo. I'm a medical laboratory officer from Kenya, and I've been following this webinar. Thank you, the presenters. You are really educating us. Oh, I have a question on Sierra Leone. I heard the presenters giving us some findings which they did in Sierra Leone. So my question goes that in case of advanced HIV, I've only heard them talking about the CD4 and viral load. What about other cases of cryptococcal meningitis? Are the labs able to do cryptococcal meningitis test, hepatitis B, and any other tests that those living with HIV are prone to? So I don't know, is the Ministry of Health in Sierra Leone plus the partners, are they able to support those tests that I've mentioned? Thank you.
Martin, are you clear on the
Thank
question,
you.
Martin?
Yes,
Martin?
yes, I'm here. Thank you for the question. Actually, Salties and Natives is both of us are working on a grant through from Orium Institute, specifically focused on the histo and cryptococcal meningitis. We have selected sites where we are piloting these, and we are tracking data so that we can identify those with cryptococcal meningitis and refer them to Connaught, the tertiary hospital here in Sierra Leone for further management and care here in Freetown. So the answer is yes. We've started work on that here in Sierra Leone, and we are seeing alarming numbers. The data actually from Sierra Leone, particularly for AHD, is not really encouraging, and we are doing it here. Thank you, and over.
Thank you.
Thank you so much to our attendees as well as our panelists and our interpreters and ASLM who made this webinar possible and supported us as in ITPC with all of the logistics. And lastly, once again, thank you to our country partners of whom we rely on your data and for making this this project or this webinar possible. And specific thank you to Tracy Swan, our clinical advisor at ITPC, who always provides up-to-date WHO guidelines and information and keeps us ahead of what we need to do. With that said, I will hand you over to Nadia Rafif, who will provide the closing remarks. Thank you.
Yeah, thank you, Pragashni. I will be very, very short because we already 2 minutes past the time. Again, thank you on behalf of ITPC to everyone. And maybe my last comment will be that prevention depends on diagnostic depend on accountability, and accountability depend on community. So if we really want prevention that truly work, let's ensure the accessibility and quality of to essential diagnostic tests, and let's work on that together. Thank you, everyone, and we keep in touch, and we'll be sharing the recording and the slide. Thank you. Have a lovely evening.